Now, moving on to our first section, that is we will be discussing the burst and teardrop fractures of the subaxial spine. We will be discussing in this section the Ferguson and Allen classification, the SLIC scoring system, and then the morphological burst and teardrop fractures, what they are, or how they look like on X-rays, and what is their management. And then we will discuss the flexion injuries with wedge compression fractures of the cervical vertebral bodies. Now, as you know, the lower cervical spine is found from C3 till C7, and it is actually called as the subaxial spine. As I told you, it's all the occiput C1, C2 are upper cervical spine, and from C3 till C7 it's the subaxial spine. The usually different characteristics could be present, but usually these characteristic fracture patterns can be divided into either the burst type or the teardrop type, depending upon the mechanism of injury, whether it's hyperextension, hyperflexion, or it's the axial compression or not. Ferguson and Allen classification actually defines the subaxial spine fractures based on the morphological classification. It could be a compression fracture due to subaxial loading of the over the neck. It could be a vertical compression. It could be a distractive flexion in which there is hyperflexion as well as forward translation of the vertebra. It could be compressive extension, that is the hyperflexion with axial load. This could be distractive extension as well, in which there is hyperextension with backward translation of the one vertebra over the other. Or it would be lateral flexion injuries, in which there is actually a increased lateral flexion of one vertebra over the other, leading to vertebral body injuries. Now, patterns can range from stable injuries to unstable. What is important to know is that when we are viewing these X-rays and these fractures, what is first needs to be determined whether this is a stable injury or it's an unstable injury. Because if it's stable, it can be easily treated conservatively, but if it's unstable, it needs fixation. And what are the factors which makes it unstable? It depends upon the degree of displacement, that is one factor, and extent of posterior ligamentous injury. If posterior ligamentous complex is disrupted, that is the transverse spinous processes, the interspinous ligament, and transverse spinous ligaments, if these all are disrupted, then most likely this is an unstable injury. And if there is displacement, until unless there will be disruption of posterior ligamentous complex, there will be no anterior translation of the one vertebra over the other. So if there is translation and there is disruption, most likely it's an unstable injury. This is called as subaxial lower cervical spine injury classification, or SLIC scoring system. Though it depends, it actually takes into account different things. One is the three main character out of the three main, one is the morphology of the injury. When I talk about morphology, that means what type of fracture it is. Is it a burst fracture? Is it a compression fracture? Is it a distraction injury? Is it a flexion-distraction? Is it extension-distraction? This all comes under the morphological characteristics of the fracture pattern. Then the second most important is the discoligamentous complex. And when we talk about discoligamentous complex, it is mainly the posterior ligamentous complex which needs to be considered, because that provides the main stability to the vertebra. And then thirdly, the neurological status, whether the patient has a neurological compromise or not. Neurological compromise is an absolute indication for surgical fixation. Now, SLIC actually takes into multiple accounts, actually gives them points. And when you have certain level of points which actually determine whether how much the injury severity is. In morphological characteristics, if there's no abnormality, you give it a 0. If it's compression, you give it 1. If it's compression with burst, which means there was an axial load which has actually disrupted the body very much, it becomes 2. If it's a distraction injury, it becomes 3. And if it's disrupted, that looks like disrupted, then it becomes 4, because then posterior spinous process have opened up. Coming to the discoligamentous complex, this could be intact, this could be indeterminate, or it could be disrupted. If it appears intact, that means there is no spinous process widening and there is no anterior translation, then you give it a 0. If it cannot be determined and there is a high index of suspicion, kind of considering the kind of injury it is, then you give it a 1. Otherwise, if it appears disrupted, give it 2 points. Coming to the neurological status of the patient, if it's intact, it's 0. Root injury only, it becomes 1. It's a complete cord injury, it becomes 2. If it's an incomplete cord injury, it's 3. Now this is an important part over here. If it's an incomplete cord injury, this means it's an unstable fracture and can progress to complete cord injury. But if the complete cord injury has already occurred, this means then it's actually from prognosis point of view may be of not of much value, and it may have poor prognosis as compared to incomplete cord injury. So in terms of patient perspective, you can save the spinal cord if it's incomplete cord injury, and you need to be more aggressive in your treatment. That is why it's been given 3 points rather than 2 points. And complete cord injury is actually given 2 points because whatever the damage has, it has actually occurred now. You cannot revert it back. And if it's neurological deficit with continuous cord compression, setting of neurological deficit, that will give you +1. You add these 3 points, you give it a score, and if the score comes higher, that means it requires more of a surgical fixation rather than conservative treatment. Now there are two types of fractures called as one is called the burst fracture, another is called as teardrop fracture. These are actually the severe injuries which are due to axial compression of the cervical spine with flexion, usually giving in a diving and athletic accidents. Now there are actually axial load is occurring in both of them. In one, there's axial loading only, which is leading to compression type of injury. In the second type, this axial load leading to compression as well as forward flexion of the vertebra, leading to teardrop type of fracture. Now when we come to teardrop, as I told you, it occurs with axial load compression with increasing flexion moment. Then what results is when the one vertebra rotates over the another, this anterior inferior part of this vertebra is actually what is damaged, leading to anterior inferior fragment of the vertebral body which gets sheared off, producing an eponymous teardrop on the lateral x-ray. If you see it on the lateral x-ray, if you can appreciate it over here, this is probably the fracture is not very well appreciated in C3 here, and because of the increased flexion, there's overloading of this segment, that is the anterior inferior fragment, which is actually leads to fracture. Now it could be a burst fracture as well. Now when it's a burst fracture, it actually means that the vertebral body is crushed in the neutral position of the neck. That is, there is actually axial loading with compression fracture in neutral. There is no excessive hyperflexion in the neck. This leads to burst fracture. In both of these type fracture, the risk of posterior displacement of the vertebral body fragment is important because there is obviously compression injury. The vertebral body is actually crushed under the axial load. These fragments can be pushed back into the canal, leading to severe neurological compromise and canal compromise as well. So there is always a risk of spinal cord injury. So what's important now is to, once we know that what is the morphology, what we need to determine is whether it is stable or unstable injury. On plain x-rays, what would they look like? They would either show a crust of the vertebral body, it could be a burst fracture, or there could be flexion deformity with triangular fragments separated by anterior and inferior edge of the fracture vertebra. This could be a teardrop. Although it looks innocent, but to be honest, it's never that innocent. It's highly unstable type of a variety, and these highly unstable injuries lead to anterior column disruption and need immobilization, and most immobilization is actually done by surgical fixation. Now coming to, whenever we get an x-ray, if the patient, there is no neurological compromise, the patient is quite stable, it's better to get a CT as well as MRI. Why? Because CT will actually tell us the detailed morphological characteristics of the fracture and would actually demonstrate whether the associated bony injuries and canal compression or not. And then we need to get an MRI as well. What would MRI tell us? That what about the discoligamentous complex, whether the disc is intact or not, whether the ligaments of the posterior ligamentous complex are intact or not, and they can be confirmed with MRI. Once we confirm that, we know that whether the posterior ligamentous complex and discoligamentous complex is intact or not, and by the CT we know what type of fracture it is. Is it a burst fracture? Is it a teardrop fracture? Now that will help us to determine whether it's a stable or unstable injury. So if it's stable, then you can go for conservative, but usually these burst or teardrop fractures are associated with unstable injuries, and they are associated with discoligamentous complex disruption. Therefore, conservative treatment is usually a poor option due to high degree of instability. There's increased likelihood of kyphosis, spinal cord compression, because the fragments can go back into the canal. Due to this flexion of the one vertebra that can lead to excessive kyphosis, because usually the cervical spine is a normal lordotic curve. The patient may be quadriplegic, although if it's incomplete spinal cord injury, this can progress to complete spinal cord injury. And with cervical spine injury, that means quadriplegia. With prolonged recumbence in the traction is not cost effective, that there are a lot of other problems with the patient as well, being bedridden for a long time. Then there are problems of bed sores, venous thrombosis, venous thromboembolism, and all these factors actually come into play as well. Usually carry a significant morbidity, so it's better to treat them with surgery rather than treat them conservatively with some kind of a hard or rigid collar. So what's the surgical management? Surgical management, the primary goal is to stabilization and to neurologically decompress the canal if it is compromised. Patient is initially stabilized in traction. If severe posterior disruption, posterior stabilization is also indicated. And usually in most of the cases, the discoligamentous complex is disrupted and that requires a posterior fixation. Optimized medically with respect to spinal cord, appropriately imaged. First you need to get a CT to know what kind of morphology is, then you need to get an MRI to know what's the status of discoligamentous complex, and then once you're done with this, we know there's a problem with the vertebral body. For that, to deal with that kind of fracture, you need to approach the cervical spine anteriorly. But as there is discoligamentous complex injury as well, therefore you need to fix the posterior column as well. So it's actually a combined approach. Both anterior as well as posterior stabilization is usually required for these kind of fractures. Now coming to the flexion-distraction injuries. As I told you, it could be axial loading compression with flexion, or it could be flexion injuries in neck is hyperflexion, and there's excessive deceleration in such a way that one part is actually translated forward and other remains stationed, this leading to a flexion distraction type of injury. It's also called as compression flexion injury as well. It depends on the instantaneous axis of rotation, that when the actual injury occurred and how much flexion is actually taking place at the subaxial spine. Spectrum could be from simple, it could be a ligamentous disruption, it could be osteoligamentous disruption, that is anterior column may be damaged and posterior ligamentous complex may be damaged as well, or it could be a complete fracture in which there is posterior ligamentous complex damage, anteriorly there is a fracture, and the vertebra also get translated over each other as well. Now if you see, this is a stage 1 in which there's only the flexion is occurring at this point. It could only lead to the fracture of the anterior vertebral body only, or this could further progress into flexion leading to burst type of fracture as well as some opening up of the posterior ligamentous complex. And if this force continues and this hyperflexion as well as deceleration continues, actually the one vertebra translates over another vertebra leading to anterior and middle column disruption, as well as the posterior column also starts to open up leading to anterior, middle and posterior column disruption. So it could be simple ligamentous, it could be osteoligamentous, both could be involved as well. Now coming to the wedge compression fractures. As I told you, when there is hyperflexion is occurring at the cervical spine, the maximum strain is actually on the anterior 2/3 of the vertebral body, that is over the anterior column mainly. As the further the force continues, this results in the wedge compression fracture of the vertebral body. With intact posterior elements, the injury is stable. But if the hyperflexion, the deceleration and continues, there is actually translation of the one vertebra over the other, leading to actually the disruption of discoligamentous complex or posterior elements as well. What's important is the clinical examination is important of the posterior elements. Why? Because integrity of posterior ligamentous complex is going to determine whether the injury is stable or unstable. Now, as when we are viewing the X-rays, what we need to exclude is the posterior displacement of the vertebral body, fractures of the burst fracture which could be potentially unstable. And if you are in doubt, always go for a CT or MRI. And CT would tell us the morphology of the fracture, MRI would tell us the discoligamentous complex status. If clinically and radiological confirmation of stability, if the patient fracture looks stable, we can go for semi-rigid collar for 6 to 12 weeks. But if it looks unstable, it needs fixation through anterior as well as posterior approaches. In this section, we have briefly covered what is the subaxial spine scoring system. There is a SLIC system which takes into account the three types of characteristics: the morphology of the fracture, the neurological status of the patient, and discoligamentous complex disruption or intactness. And what is important is that there could be a simple axial load with compression and flexion injury leading to a teardrop type of fracture, or it could be a simply when the neck is in neutral position, this could be simply lead to a burst type of a fracture. What is important is whenever we have an intact subaxial spine fracture, what's important is to determine whether the fracture is stable or unstable. If this is a discoligamentous complex disruption, this is probably an unstable variety and needs a surgical fixation. If the fracture comes out after getting all the x-rays, that is a lateral view, CT and MRI, comes out to be a stable fracture, then can be treated as semi-rigid collar for 6 to 12 weeks. Thank you very much. Keep watching sqadia.com.